This lecture is entitled Pitfalls in Gynecologic Ultrasound. I have no disclosures. Before I actually get into a discussion of pitfalls and problems, I'd like to talk a little bit about how we do our pelvic ultrasound at Albert Einstein Medical Center. For several years now, we no longer require women to arrive at the department with a distended urinary bladder. If they have never had any prior pelvic imaging, either ultrasound or otherwise, we always take a brief transabdominal look. Then we make a decision about whether this patient will be better to do transabdominally or transvaginally, and occasionally a combination of both is required. The vast majority of women only have a transvaginal imaging study. Occasionally we have to wait for the bladder to fill. This, of course, makes the patients more comfortable, it helps the throughput in the department, and there are fewer people running back and forth to the bathroom. The outline of my talk is as follows. First, I'm going to talk about the uterus and particularly unusual manifestations of some of the more common entities. Then there will be some miscellaneous topics, and then I will talk about post-surgical issues, not acute post-surgical, but more chronic issues, particularly those related to cesarean section. I will also then go on to a discussion of the adnexa of a variety of tubes, and those tubes may be fallopian tubes as well as other tubular structures, vessels, bowel, and otherwise. And the last topic will be ovaries. In this group, I will discuss ovaries that do not have any particular focal mass or unusual cystic structure, but either are too large or too small and therefore are abnormal for the patient. I will also show you some atypical appearances, again, of common abnormalities, and then I'll include some of our actual M&M cases. So as far as the uterus goes, there are fibroids, there's adenomyosis, and then we'll discuss some miscellaneous topics. Most of the vast majority of fibroids are obvious and easy to deal with and easy to diagnose, but every now and then some unusual cases come across. And many of these are taken from our recorded problem cases, either problems for the technologists, a resident at night, or one of the staff. These are the initial transabdominal measurements of a uterus. And the question I would pose to you is, do you think these are correct? That this is a nice sagittal view of an enlarged uterus and a transverse view. Actually, upon further transvaginal imaging, we found a fairly normal-looking body of the uterus and then could see the edge of what appeared to be a very large myoma that was not easily imaged completely on ultrasound, on transvaginal imaging. So we went back to the transabdominal and were able to find that normal piece of uterus with the endometrium, and actually this uterus just has one very large exophytic myoma rather than a diffusely myomatous uterus. And that's a particularly important thing in terms of therapy for this patient. So sometimes a single exophytic myoma may make one think that the entire uterus is enlarged when actually there's a normal body of the uterus there. Every now and then this issue arises. Is this solid adnexal appearing mass actually part of the uterus, or is it adnexal? And one of the things that we found very useful is to use color Doppler and look for bridging vessels. These type of bridging vessels would indicate that this is a subserosal myoma. Here's another one. Is this an enlarged diffusely myomatous or adenomatous uterus? This is transabdominal with bladder and uterus, and these were the measurements that were given to us on the transabdominal study. Actually, this was a large patient and difficult to image, but upon pressing a bit more on the transabdominally, we could find that this little structure here was the main body of the uterus. This was a sagittal view towards the left, and we could see the endometrium. And once again, there was one large single myoma. Here's an unusual manifestation of a common disease. There's a lobulated cystic structure along the right side of the uterus. And most of the time, cystic structures are adnexal and solid masses are uterine. However, we were able to find the right ovary in this patient, and this structure, therefore, might be related to the uterus. This is transabdominal and transvaginal. In this case, it was opted to obtain an MR, which confirmed our suspicion on ultrasound that this was actually a cystic myoma. This is the claw sign. In other words, this cyst arises from the uterus because of the little claw sign around it, which you can actually appreciate on sonography. Here's an unusual case. These are the initial images presented, and the question was, is this the endometrium in this uterus, and is it extremely thick even for a premenopausal patient? So in this case, we definitely went transvaginally in this patient, and lo and behold, the endometrial cavity was slightly expanded with some complex fluid and possibly a small myoma, but this large echogenic area was not the endometrium. This patient also went on to an MR for problem solving, and here is a high intensity lesion as well on T2, and with fat saturation it decreased in enhancement, and this is a lipoleiomyoma. So I've now showed you some atypical appearances of fibroids, and fibroids are common, but every now and then there will be an atypical appearance. The cystic ones are usually due to degeneration of a myoma outgrowing its blood supply, and when it degenerates it can liquefy and become cystic. Obviously calcification can occur, and that's much more common. Lipoleiomyomas are very rare smooth muscle tumor myomas that have fatty change inside. Here's a not uncommon, but sometimes underdiagnosed or potentially overdiagnosed issue. This is a 64-year-old woman, and as you notice, there are some chunky calcifications in this uterus, and one might be quick to make the diagnosis of calcified myoma. However, if you look a little bit more carefully, these calcifications line up around the periphery of the uterus, and what this represents is something called Monkeyberg sclerosis, or just generally atherosclerosis, which clearly is a diffuse problem in the body, but can occur in the peripheral vessels in the uterus. On this CT scan, you can see the same effect here of calcifications peripherally. It's more common and accelerated in diabetics and those with chronic kidney disease, and should not be mistaken for a myoma. So moving along to other issues in the uterus, here is the initial sagittal view transabdominally of the uterus, and the question was, is this a myoma? The person doing the scan, the technologist, measured it as a myoma. But a little bit more careful scanning and using color Doppler obtained a different diagnosis. You notice with the color Doppler, there are linear areas of vascularity that penetrate this area rather than the ring-like vascularity so typical of a myoma. And further imaging shows that in the sagittal view, the endometrium is here in the uterus. The posterior myometrium is much thicker than the anterior myometrium, and there are some tiny little cystic areas. Mostly this is increased in echogenicity. It doesn't cause significant attenuation of the sound beam, and this represents focal adenomyosis, which every now and then can be misinterpreted for a fibroid, but certainly has different issues for the patient. Here's a patient, sagittal and transverse views transvaginally of the uterus, and this study was interpreted for the patient as having a small polyp in the endometrial cavity. But if you look a little bit more carefully, you notice that there really are no borders of this structure. There are these pencil-thin shadows coming out. It is echogenic, and then there are some tiny cystic spaces. The problem solver here again was MR, which showed a markedly thickened junctional zone and diffuse adenomyosis, which in this case simulated a possible polyp, but there was no polyp. Here's another cause of an enlarged, so-called enlarged uterus. This is the sagittal view of the uterus. It looks fairly normal. On transverse, it's up to almost 6 centimeters, and it sort of looks like a wide area of endometrium. There was no focal abnormality, but overall the measurements were enlarged. And we did a reconstruction in this patient, and you can see that this is actually an anomaly, a septate uterus, and often these types of anomalies can result in a larger uterus. Here's a problem that arises every now and then, and here's a tip for how to get around it. This patient was a 90-year-old with postmenopausal bleeding, and I would say in really elderly patients, this is often the most common reason we're asked to scan. As happens sometimes, she was incontinent and had had a hip fracture that she was recovering from. And those factors made it very difficult to image her. We looked initially transabdominally as she came to us. She only had a small amount of urine in the bladder, and the question was whether she actually even had a uterus, and she was unable to tell us that. So we couldn't fill her bladder. We could not scan her transvaginally because of her other issues, and we have found that in these patients, the best thing to do is a transrectal study. It may seem counterintuitive, or it may seem odd to do this, but actually for imaging the uterus, particularly the endometrium, this is an excellent way to scan. These images are flipped, and here's the probe in the rectum, and you can very nicely see the cervix and the body of the uterus in sagittal, and this is more or less of a coronal view. You don't have quite as much leeway by imaging in the rectum, and it's unlikely that you'll be able to image the adnexa, but for the specific purpose of evaluating the endometrium, this is a very good way to image. You can see that there is a little bit of fluid in her endocervical and endometrial canal, but the actual endometrium was normal in thickness, and the problem was solved. And I should also add, this is actually quite easily tolerated and not difficult to do.